Good afternoon, everyone. My name is Gerald. We have Brandon, Emma, McKenna, and Jackie, and our QI Change project is on diabetic retinopathy screening. And so for a brief introduction, diabetic retinopathy is a complication associated with diabetes mellitus type 1, type 2, and it's the leading cause of blindness and visual dysfunction in the working age population. And that's because diabetes is such a prevalent condition or disease in our population as well. It essentially affects 28.5% of individuals over the age of 40. And it's very concerning because this is a very preventable issue worldwide. And early detections of diabetic retinopathy can prevent these complications. Usually the complications are seen at later stages, and it's very preventable if we just implement more screenings. So the current community health clinic that we are focusing on today also doesn't charge patients for diabetic retinopathy screening, as it's provided with federal funding. So a lot of signs to implement a change towards early detections. And so our global aim is to improve screening rates for diabetic retinopathy in the diabetic population. And we expect that by working on this problem, we'll understand why the rates for this type of screening are low. And it's important for us to work on this because it can be a way to minimize the severity and vision complications.
A little bit of background about diabetic retinopathy is diabetic retinopathy is a complication of diabetes. It affects the eyes and it can cause blindness in those who have it. It's caused by damage to the blood vessels, and it continues to the tissue of the eye and retina gets sensitive, and it can lead to total blindness. Vision loss has significant impact on the lives of those who experience it. And it's pretty safe to say that the negative results of diabetic retinopathy are accounted as physical difficulties for the one who have it. And those can be associated with vision impairment, but besides that, it can lead to depression and other comorbidities. Deterioration of the eyesight can feel frightening and overwhelming when it first starts because it leaves those patients vulnerable, and it leaves them with the doubts: will they ever be able to recover? Will they ever be able to gain their independence back? Are they going to be able to have medical care, proper treatment? And bottom line, just are they going to be able to care for themselves and their families? So with that being said, eventually it will lead to health consequences, which it will be a little bit more than just vision loss. It will end up affecting their quality of life, including their mental health, cognition, and social function. Diabetic retinopathy, the question is, how can we prevent that? There are certain types of screening, which is inviting patient for screening after identifying they have a diabetic diagnosis in their database. And that's an opportunity to kind of catch that on early. According to one of the articles we came across from Williams, shares that there are barriers to have regular eye exam and to screen. And this screening is normally, it's recommended to be done annually.
So for our root cause analysis, we're going to ask 5 whys to why the screening rates for diabetic retinopathy are so low. So our first why that we came up with is the patients are not showing up for their screenings. Well, why? There's a lack of education about the importance of screening for diabetic retinopathy. Well, why? The patients are not being informed properly by the clinical staff. And why they aren't being informed by the clinical staff is that there's a general uncertainty amongst the staff regarding the screening protocol. And that could be like how to do the screenings, where the patients need to go for the screening. So there's just this uncertainty of how this procedure is done. And why is there's the lack of the standard protocol. So not every single staff member is notified of how the screening process is supposed to be completed. And then our final why is there are no prior practices to have them be scheduled for an appointment for their diabetes alongside an appointment to get their diabetic retinopathy screening, which would be a overall 2 appointment schedules being made procedure.
So this is our fishbone diagram. The effect or the problem being lack of early detection of diabetic retinopathy. And some of the causes in regards to manpower would be providers and staff are inconsistent with their follow-up regimens. Patients miss their appointments for travel, financial, or emotional reasons. And then some of the causes in regards to machines would be patients lack transportation to get to their DR appointment screenings. Patients do not have proper translation services to understand their education, or the EHR may not be updated with the correct contact info. Some of the causes in regards to methods would be the lack of standard protocol for screening and follow-up, the lack of standard protocol for tracking patients after their missed appointments, and then some of the causes in regards to materials would be the DR screening is not notifying the staff with the current software, or too many resources were spent for both the patient and the staff on booking the DR screening appointments.
So for the change theory that we selected for this project, we selected Cotter's change management theory. This is one of the most popular and adopted theories that was devised by John K. Potter, who was a Harvard Business School professor and author of books focused on change management. This theory features 8 stages that focus on key principles that are focused on making the change. So we chose this theory for the following reasons. 1, it is easy to follow and implement. 2nd, it provides clear descriptions and guidance on the entire process of change. 3rd, this theory depends and is centered on the employees. So it doesn't really involve much of the outside forces or external forces. We're more focused on the involvement of the employees and how well they embrace and accept this change. Lastly, this theory helps to build acceptability to change, which is so important when introducing a change to protocol. And also we can help make a change to the culture of the work environment, which is one thing we would want to accomplish with this project. So what are the 8 stages of Cotter's management theory? Well, the first one is increased urgency. This step involves creating a sense of urgency amongst people so as to motivate them to move forward towards the goal or the objectives. Second step is, or the second stage is build the team. This step is associated with getting the right people on the right team by selecting a mix of skills, knowledge, and commitment. The third step or third stage is get the vision correct. This stage is related to creating the correct vision by taking into account not just the strategy, but also the creativity, emotional connect, and objectives. The fourth stage is communicate. Communication with people regarding change and its need is also an important part of the change management theory by Cotter. Step 5 is get things moving. In order to get things moving or empower action, one needs to get the support of the team and remove the roadblocks and implement feedback in a constructive way. The sixth one is focus on short-term goals. Focusing on short-term goals and dividing the ultimate goal into small and achievable parts is a good way to achieve success without too much pressure. 7 is don't give up. Persistence is the key to success, and it's important that we don't give up while this process of change management is going on, no matter how tough things may seem. Number 8, and the last stage, is incorporating change. Besides managing change effectively, it is important to reinforce it and make it a part of the workplace culture. So how does this apply for our project? For our project, we are focused on a community health clinic as part of Riverside University Health System. We want to introduce a new protocol for this clinic to implement to better diabetic retinopathy screening rates. We will use this theory to help employees in this clinic to help prepare them for this change and work with these employees to accept this new change as they add this to their daily routine of work. So for stage 1, increase urgency. Well, this urgency can stem from the low screening rates in the United States. So the screening rates in the United States are about 35 to 65%. And this is not meeting the goals of Healthy People 2030, where the target is 70.3. In the clinic that we are basing this project off of, this particular clinic had a screening rate of about 40%, and their goal was in the 80s. And so it is through these statistics here that creates this urgency to help motivate the clinic, as well as the members and employees of this clinic, to want to achieve greater compliance of diabetic patients to get their diabetic eye exams done. So the second step is building the team. So of course, we want to get the right combination of people to help carry out this project. So they could be the physicians, medical assistants, retinal techs, case managers, the clinic manager, etc. Next, we need to have the right vision. We need that vision to be clear and understandable. We need to identify core values. We can come up with a mission statement, and we can ensure that everyone on the team can communicate the vision clearly. Next is communicate. So we need to communicate the vision. And how can we do that? Well, we can do that by demonstrating the behaviors required to achieve this new change. And we can also talk to employees, address their concerns or anxieties about this new protocol. And it's important that we stay open and honest to any of their concerns. Next is focus on short-term goals. So as an example of what can be done with this particular project is we could perhaps dedicate a month focus entirely on just diabetic eye exams. And then from there on, we can try and in the next following months, just try to incorporate this more into their daily routine so that it just becomes part of their regular work duties. 7 is don't give up. So perhaps even with the implementation of this project, we only get compliance up to 70%, and we don't reach that 80% that the clinic wants to reach. But we should remember that we came such a far way from 40%, and we should remind the team members and these employees that we still made a great improvement, and it's important that we continue to keep members of the team motivated. And lastly, incorporating change, number 8. So as this project goes on, maybe there are changes along the way. Perhaps maybe the project or the implementation of this new protocol doesn't go exactly as planned, and we need to come up with alternative methods. Well, it's important that we stay flexible and try to make changes that can better screening rates, and also we can even better tailor conversations with our patients to convince them to come in to get their diabetic eye exam done.
Okay, so for the stakeholder analysis, the people that we're going to be looking at is for the internal stakeholders, the employees, the nursing administrators, the medical directors, and the research coordinators. But then we're also going to be looking externally from the hospital for the external stakeholders with the community, the patients and their family, insurance providers, consultants, legislators, and government agencies. And so to communicate with the other stakeholders and develop a buy-in, different methods. One could be hosting panels during conferences, scientific conferences about the importance of diabetic retinopathy screening, and have current literature ready for evidence-based practices conveying the effectiveness of early diabetic retinopathy screenings towards prevention, host community festivals and events to raise awareness for diabetic retinopathy. I know that Padre Foundation is responsible for type 1 diabetes awareness, so we can have an extra panel as well during their festivals for the community so that we can bring more awareness towards this issue. We can meet with insurance providers and administrators to discuss financial benefits of early diabetic retinopathy screenings. So having more screenings and more preventative measures would equal less money spent treating later stages of diabetic retinopathy, and also advocate for diabetic retinopathy during legislative meetings or sending letters to congressmen/representatives, just supporting policies.
We are going to continue with the marketing. This is another important part to achieve our goal and minimize complication of diabetic retinopathy. How do we do that? It involves product, people, promotion, price, and place. Under the products, what's included in there? It's screening for diabetic retinopathy and health education. Health education plays a key role because all the patient must be encouraged, all the ones who have diabetes, to get a comprehensive annual vision exam, as well as a retinal exam. We also, as a healthcare professional, must remind them that most vision complications are not obvious, and they are not detected with a simple exam. People who falls under that category: individual diagnosed with diabetes and pre-diabetes. Promotion, how do we promote them? That is to be offered by the physician, by nurses, ophthalmologists, optometrists, endocrinologists, as well as other associated healthcare places that treat diabetes or work and focus on the healthcare exam for the eye vision. And then under price, it's very important to improve the cost of the screening and make it accessible to anyone who has diabetes. And those screening can either be provided at no cost, which is covered fully by insurance, or it can be partially or on a sliding scale. And then places where this is offered: hospitals, clinics, optometrists, and other healthcare settings.
Okay, and then some additional costs we would need to focus on is for this project is hiring case managers in this clinic to perform follow-up care for the patients after diabetic retinopathy screenings, and then have additional funding to fund screening days for the retinal tech, because maybe the retinal tech would only come on Wednesdays for screenings, but we would need them to come maybe 3 days a week instead of just one. And so after looking at fees, case manager hiring fees would most likely charge for a part-time service of about $60K a year, while retinal tech fees for funding would have additional days of service, and they would cost an additional $30K a year. So about $90K a year for these for this project to occur.
So this is our force field analysis. Our proposed change is any patient being scheduled for an appointment regarding DM would be automatically scheduled for a second appointment for a DR screening during the same visit. Some of the forces for this change would be the clinics, doctors and staff, and the insurance companies. The clinics would be for the change because more screenings equals less money spent maybe in later stages of diabetic retinopathy, and more appointments could equal more money. And then for the insurance companies, they would make more money off of the diagnostic tests, and official diagnoses means possible prescribed medications equaling more money as well. And then for the doctors and staff, the possible diagnosis means early detection and intervention for the patients, which is always great. And then some of the forces against the change would be the clients, clerical staff, and doctors. And the clients would be against the change because that would mean more work to go to another appointment, time away from work. They may not speak English. They might have no access to technology or might be technology illiterate. They may not have a car, they may have issues getting to the appointment, or they may just be scared of the potential diagnosis. For the clerical staff, it would mean more effort for them to schedule patients in 2 appointments in 1 day. More appointments may equal more paperwork for them to do. And then the doctors are also against, possibly because more patients and longer appointments could mean just a longer day for them. And then more teaching is also more work for them as well. So some of the strategies to mitigate these restraining factors would be to educate any patient who is resistant to have this appointment scheduled about the importance of the screening and inform them about the quick progression of the disease as well. The clerical staff will try to make the screening appointments directly after their other appointment to decrease the overall wait time in the clinic. And the clerical staff will be incentivized with a gift card for the most DR screenings scheduled and performed each month.
So the goal is to decrease the amount of patients who have diabetic retinopathy, as well as that will be measured by the amount of patients diagnosed per year in United States. And how do we achieve that, and how do we improve the screening process is it will be further discussed in the remaining slides. And these variables will include income, health literacy, and accessibility. So the problem is screening diabetic patient for retinopathy enables early detection for these patients, as well as it provides them an opportunity for an early referral when needed, as well as provide the treatment and hopefully prevent further complication, as well as an opportunity for education about those risk factors, which can be modified by treatment and behavioral changes. However, due to various reasons, such as being low income or not having easy access to medical care, many who have diabetes are not screened as they should annually, or even made aware and have a better understanding what complication of diabetic neuropathy are.
So there are 3 specific tasks that we plan to do with our intervention on how to address this problem. The first task is we are going to have clerical staff schedule 2 appointments for any patient coming into the clinic for any appointment that is regarding diabetes. So one appointment is going to be for their standard appointment with their primary provider, and the other appointment is going to be one for their diabetic retinopathy screening on the same day. And how we mentioned earlier, preferably around the same time directly after the initial appointment. This is going to be done by clerical staff. It's going to be done when the patient initially makes their appointment with the provider regarding diabetes, and it's going to be done in the clinic. The second task is that we are going to educate patients about the importance of attending their diabetic retinopathy appointment. So that's going to be done by the doctors, and they're going to do this while they're wrapping up their initial appointment, because with this intervention, every person who comes in to see their doctor who has diabetes is going to automatically have that second appointment for their screening made. So this should become second nature to doctors, where as they're wrapping up their appointment, they're going to be educating the patient, informing them that you have this appointment following your current appointment, and so make sure to attend it. They're going to be telling them about progression of the disease and the importance of having the screening, and that's all going to be taking place in the examination room. And lastly, we're going to contact those that missed their appointment with a follow-up call, and so that way they're aware that their appointment was missed and that their screening appointment was missed, and they're going to be given a chance to reschedule at the earliest convenience. The clerical staff are going to be asking the patients, when is best for them to get the best chance of the patients actually coming in for their appointment. And we're also going to keep clear records of the follow-up appointments and reasons why their appointment was missed. And that's going to be talked about in a later slide. And that's all going to be done within a half hour of an appointment of a patient missing their appointment. So that way, the follow-up and the reschedule can get placed as soon as possible. Our predictions are 3 things: that there will be an increase in the DR appointments being made for patients who have diabetes. We're going to measure this by the number of DR screening appointments being made alongside the diabetes appointments. Our second prediction is there will be an increase in the number of patients who attend their diabetic retinopathy screening appointment, and that's going to be measured with the overall number of patients who had an appointment for their DR screening and who actually attended. And our last prediction is that patients will understand the importance of getting their yearly DR screening notes and that's going to be measured by notes in the patient charts that identify patients. Patient education was provided by the doctor. To do this and to collect all of our data, we're going to do it over a span of 6 months. So for 6 months, our clinic will utilize this intervention of making the 2 appointments at the same time, one for diabetes and one for the diabetic retinopathy screening. And we're going to record the data of patients that show up to the DR screening appointments and those who do not. So we're going to compare the data at the no-show rates at 1 month, 3 months, and 6 months. And hopefully after seeing a stable results and an increase in the DR screening rates, we will implement this intervention at a larger scale, maybe to more clinics or maybe to, the general diabetes population in general.
So if this intervention is successful, we predict that we will see higher rates of patients being screened for diabetic retinopathy. And the outcome of that will hopefully be decreased severity of diabetic retinopathy due to the early screening and intervention. And then another prediction that we have is increased patient satisfaction for appointment accommodation related to the clustered care. And then the outcome of that would potentially be due to the increased satisfaction with the clustered care, patients will be less likely to miss their appointments.
So after evaluating the results of our study, our ACT, which is going to be any follow-up that we do to improve the study. So we're going to obtain all of that qualitative data regarding why patients did not show up to their initial appointment or did not show up to their DR screening appointment. And we're going to do a categorical descriptive analysis where we're going to gather up all of the responses and group together specific barriers or challenges that the patients faced. And then we're going to address the barriers and come up with solutions for each. So some typical barriers are childcare, transportation, and personal scheduling conflicts. So if their issue was childcare, we're going to encourage our patients to bring in, their little ones, and we're going to assure them that there's going to be, some materials available in the rooms to entertain their child while they're being seen by the doctor. We're going to notify them of the total duration that they'll be spending in the clinic to ensure them that them and their child won't be there all day. If it's transportation, we're going to tell the clerical staff to encourage scheduling their appointments around the bus routes. If they can't catch a bus at that time, getting an appointment where the patient understands the bus routes is going to be really important. And then also personal schedule. There's work conflicts, there's, picking up children from school conflicts. So we're going to really enforce that the clerical staff ask the patient what time is best for them. We don't want the clerical staff just saying, okay, I made you an appointment at this time with your DR appointment at this time, make sure to show up. No, this all needs to be at the patient's most convenient time, and the patient should have full, awareness of when their appointment is being made, so that way we get the best chance of them actually showing up.
Okay, and to test for quality assurance, the study, like Jackie was saying, will be conducted for a duration of 6 months. We'll evaluate them at the 1 month and the 3 month and then the 6 month mark. And we'll use this baseline data conducted with diabetic retinopathy screenings for 6 months prior to the intervention, and then compare it to the conducted diabetic retinopathy screenings after applying our implementation, just to see if the implementation was effective or not. And the specific roles to be evaluated would be the receptionist, who is responsible for scheduling the 2 appointments for the patients, but they will also be collecting data for the ACT portion from patients regarding why the patients are unable to stay for the 2 consecutive appointments if they come up with anything. And also we'll evaluate the provider, who is going to be responsible for educating the patients about the importance of staying for their diabetic retinopathy appointment and providing further education for any of the questions that the patients may have.
So in regards to future planning, if this intervention of cluster care is successful, then we will implement a system where a reminder will come up on the EHR that shows that a yearly DR screening is coming up and they need to schedule the appointment. And then we will focus our studies more on improving the compliance for patients who don't show up for their diabetic retinopathy screenings at all. And then a new tool that can be used to combat the lack of adherence to follow-up appointments and screening is telemedicine. And by using a digital retinal camera and transmitting the images to a remote location for diagnosis, the screening for DR can be conducted without an ophthalmologist present locally. So with this technology, patients in a more rural or underserved setting are more able to receive the appropriate screenings and more often. And these are our references, and thank you for listening.